On this episode of Message Meg, for years, women have navigated the physical and emotional shifts that come with menopause. But now, a powerful conversation is gaining momentum, one that could change how millions approach their health: hormone replacement therapy. How does it impact your overall health from head to toe? And when should you start on your hormone replacement? Tonight, we bring you parts 3 and 4 of our special series with 3 leading physician specialists who'll break down the latest science women need to know. Then, can hormones make your skin look more youthful? Estrogen in skincare? A top dermatologist weighs in on the science behind the beauty claims. The conversation starts now. Now, in today's episode, we have 3 specialists in hormone replacement for women. They are all board-certified obstetrician and gynecologists who are clinicians practicing HRT at the Menopause and Women's Wellness Center at Ochsner Health here in New Orleans. They are Dr. Jennifer Brunet, Dr. Elizabeth LePere, and Dr. Jody Horton, and welcome to you all. Let's first talk about women got scared about 25 years ago with the Women's Health Initiative. That's now, a lot of it's been proven not to have been done well. Dr. Brunet, do you want to start with that?
Sure. I think that's where most of the patients' hesitancy and comes from was the Women's Health Initiative back in 2000 that published a lot of data showing increased risk in breast cancer, stroke, dementia, and what in the years subsequent to that, doctors were taking patients off of HRT because of these fears. And what we have seen is that the patient population that was being studied in that study was not the patient population that we are typically starting on hormone replacement therapy. So most of our women are either perimenopausal, so those are your transition years prior to menopause, or women that are immediately postmenopausal and within that first 10 years after menopause. And these are the women that are going to find the most benefit from hormone replacement therapy. And so when you look at the increased risk for stroke, dementia, you really have to look at what were the comorbidities of that patient population when they were put on hormone replacement therapy in the Women's Health Initiative.
Because they were all ages, and I understand they did a one-size-fits-all. They don't do the customized as y'all practice now. They didn't take blood levels to see, were those oral hormones absorbing into the blood? And that's not the way you practice now. Let's talk about what you do now. The delivery system, Dr. LePere. How do you believe in not doing oral and mostly patches and gels and implants for women who can take implants?
So just to back up, part of the issue with that too was that those were synthetic hormones.
Yep.
And now we use what we call bioidentical. Bioidentical does not necessarily mean compounded, but bioidentical is when we give you estrogen, it's estradiol. It's not synthetic estrogen. So that's why we do primarily use transdermal in the form of a patch or a gel, primarily. There are other ways to do it, but we tend to stay away from oral, but certainly we don't use synthetic hormones anymore.
Is it as simple to think of when your ovaries are making your 3 hormones, testosterone, progesterone, and estrogen, they're putting it into your blood. They're not squirting them down your throat and down your digestive tract. So it's better to take hormones where they go straight to your blood. Like, I'm on injections now because the patches stopped working for me as I aged. Is that the thinking, is that not to do oral?
Well, part of it's when you're on an oral, that goes through your liver and it does go through your gut. So when you're on a transdermal, it bypasses your liver. So that takes some of the risk out for some patients that might have certain conditions. I think you do often get better absorption, but you also have a range of doses that are more available than on some other like orals.
Okay, well, let's talk about, I know I get my blood checked to see where am I, where do I need to be. There are a lot of doctors who won't check the blood level to see, okay, Meg needs this much, but Jane Doe needs that much. So do y'all all believe in checking blood levels for the 3 hormones so you have an idea of where to put your patient?
I typically don't. So I go by symptoms. So it's kind of one of those rare things where you look at what symptoms the patient's having, and that's why it's really custom to what symptoms patients are having. I certainly wouldn't, I would believe a patient, they came and said, I have hot flashes, night sweats, vaginal dryness. Regardless of their labs, I'm going to treat those symptoms. And then I'm going to titrate or adjust their dose based on their symptoms and whether they've gotten better or not. I would never say, oh, well, you have hot flashes, but your estrogen is normal. I'm going to believe the patient and say, okay, these are the symptoms you're having, this is how I'm going to treat you. And then I have them follow up and say, okay, are these symptoms better? Are they the same? And then adjust the medicine or even change the delivery system.
How do you feel, Dr. LePayer, about taking blood levels?
So for blood levels, the one that I definitely follow is testosterone, because testosterone, you've got to be careful, and you can get some negative side effects that can come on quickly if you're not monitoring it. The issue is, I tell my patients hormones kind of whisper, they're pulsatile, and so what I'm catching on one day might not be what you really are, and it's affected by a lot of different things. So I do look at them some, but just like a perimenopausal woman, they are often misdiagnosed because their estrogen will be a certain level, and somebody will say, oh, you shouldn't be having symptoms. Well, their estrogen's high, but it's high on that day.
Right.
So it's not that we don't check levels. I think it just depends on the patient, because you're still treating symptoms.
Well, and I think that we can all sit here and agree that one of the most common patients that you will get is the perimenopausal woman that's starting to have symptoms. And so, they think, well, wait, I'm still having periods, but I'm having night sweats, or I'm having mood swings, irritability. These things start to happen long before the menstrual cycle abnormalities. And so what I see often is they'll come in and they'll say, but I went to my previous OBGYN and he checked my blood levels and he told me that I was crazy. I'm not in perimenopause, I'm fine. And just like Liz said, they were fine on that day. And if you look at in a normal reproductive age woman, the menstrual cycle is phasic, right? So you have your follicular phase and your luteal phase. Your estrogen, those granulosa cells in the ovary are dumping out estrogen every day as that follicle is maturing. I tell patients now that are perimenopausal, I can check them today, but I'm telling you, by the time I even get the result back, the level is going to be different. And so they're not as helpful in a perimenopausal woman. Where they are helpful is in a patient that comes in, 38 years old and says, I haven't had a cycle in 6 months. She's not on birth control pills, and she's having symptoms of menopause. Where it can be helpful is, okay, are we dealing with a premature menopause or a primary ovarian failure here? And so that's where they can be helpful. As far as guiding treatment, testosterone, agreed, it's a must. Really just because they can start to get some, unwanted side effects as the levels get higher. Where I find estrogen can be helpful in some patients I do have some that I know, for example, are on injections. So I know their levels are going to be fine, but they're still complaining of hot flashes or, some other symptom. And what I'm trying to do is, in some cases, show them that, look, your estrogen levels are fine. We might need to explore a different cause for whatever symptom that you're having. And so it's not so much for me to guide my treatment as it is for me to know, okay, your estrogen levels are fine. I think we need to kind of look
somewhere else, thyroid or something.
Yeah, and it makes them also feel better too. Because remember, I have learned through my 14 going on 15 years of practice, and I'm sure they've been in practice longer than I have. A lot of treating patients is also treating their mind and treating their anxiety. And so if they know that their estrogen levels look good, it's one more checkbox that they can check off, and they know, okay, at least that's good, let me explore something else.
And so it's the estradiol, it's the progesterone, and it's the free testosterone blood level that matters more than total.
We still check total,
we check
but
we do.
Both, but
yeah. So, but yeah, I agree. I follow freeze more than I do, because that's really your active.
Well, because that comes into play with your sex hormone binding globulin and your albumin.
Yes.
And if you're really looking at free, there are different ways to measure that.
Kind of the usable, the testosterone that's being used in your body as opposed to just what's circulating.
Right.
All right. So you talked about the mind. When women went off their hormones 25 years ago with the Women's Health Initiative, the prescriptions for antidepressants doubled, for Xanax doubled, for sleeping pills doubled, and suicide rates went up. I was just reading a study about that because estrogen affects your brain. Alzheimer's goes up when you don't have your estrogen, Parkinson's, dementia, and even MS. So talk about how brain fog, women always who don't have their estrogen talk about brain fog. Talk about the difference that hormones makes on your brain. We think of it as a plumbing issue with, you know, having a baby, but it affects your brain.
Yeah, it's not really just your ovaries, it's your brain, absolutely. Women are, I mean, 2/3 of Alzheimer's patients are women. Women are 4 times more likely to have autoimmune disorders. That includes multiple sclerosis. We have more estrogen receptors in our brain than men do. Men have more androgen receptors in their brain. So there's an expert now who knocks out of the park with her bestseller, Lisa Mosconi. She's a neuroscientist, and she really has opened up this amazing dialogue about women and their brains. And it's not that menopause causes Alzheimer's, it's just we have some changes in the brain that are affected as we go through those changes. Really, puberty, pregnancy, and perimenopause, she talks about in her book, are times in our life when our brains change, and she's done scans to show that. I mean, she's got the data to finally show it. I mean, we need more research on it, but it's clear that your brain changes, and it doesn't have to be a bad thing. It just means we have to adapt and understand that, because women were called crazy. They were put in asylums and
Hysteria.
Hysteria.
Well, there was a study that Tulane did on mice that were menopausal, and when they checked on them, their hippocampus had shrunken up. That's where memory is, and they couldn't remember how to go through the maze. But the female rats that had their hormones, they remembered where the cheese was at the end of the maze. So we're not crazy, right?
But it is scary, because the brain fog, you know, you start forgetting where you put your keys, you're not remembering people's names. I have patients who come in all the time saying, I might need to have some neuro testing.
Right.
And certainly there are patients that do, but sometimes we just need to listen to them and give them reassurance, and maybe, you know, start them on HRT, look at nutrition, sleep.
That's the biggest thing,
sleep.
I always focus on sleep, like with all of my patients, because often when you ask them, what time did you go to bed? What time do you wake up? Is your sleep, you know, do you have trouble falling asleep or staying asleep? Is it interrupted? Are you going to the bathroom multiple times a night? There's so many things that we don't think about, and we always just push through. And this is happening in a time of our life where we're very busy with kids, our job, and then you're going through all these changes. And so I really focus on making sure not only are you getting the 7 hours of required sleep, but you're getting good, deep REM, restorative sleep, because that affects your anxiety, your mood, fatigue, brain fog, all of your memory. So if you start your day off like that, then, you know, it's going to be spiral.
But Dr. Horton, when you're losing your estrogen going through menopause, you don't sleep as well.
Right. Yeah.
So I read in a study where you're more likely to lose teeth if you're not on your hormone replacement after menopause because of the bone problems. Y'all agree on that one?
I'm not familiar with that.
Yeah.
I mean,
I don't think there's probably randomized control trials out there, but I think, you know, logic stands to reason. We know the effects that estrogen has on bone, and why are we to think that our jaw is any different than any other bone in our body? So I could definitely see the correlation between loss of estrogen, you know, weakening of the jaw.
Well, let's talk about bone. Osteoporosis is what I call it is your bones become like Swiss cheese. They get holes in them. And you need your estrogen. You can take all the calcium in the world, but if you have no estrogen, you can't build bone. You can't save bone. And more people die from osteoporosis than from breast cancer. Those statistics are incredible. And when you have a fall.
In terms of fractures.
So, So that is one thing a lot of times we don't talk about. We think the dowager's hump is something that is normal with aging, but if you have your estrogen, you're less likely to get that. Is that correct?
Well, I think it depends on where you are in that continuum of osteoporosis. Certainly, and I'm not an expert on osteoporosis medications, but we do know that estrogen helps. But if somebody is really down a certain path, we don't want that fracture. So sometimes they do need other medications. Estrogen can be helpful, and certainly, you know, weight-bearing exercise is critically important. Women have got to keep their muscle, and that's critically important through perimenopause and menopause, because it's the muscle that helps protect the bone, that helps prevent the fall.
Right. And if you start on your hormone replacement right at menopause, or when you're deemed, you know, that you've lost, that helps save the bone from going away.
Certainly.
So you start losing bone starting in your 30s, as well as lean muscle mass, and then it accelerates through that perimenopausal time. So I always tell people, make sure, like you said, weight-bearing exercises, 150 minutes of exercise, moderate intensity exercise per week, resistance training. That's all those weight-bearing exercises gonna help, you know, maintain your bone mass, your lean muscle mass, increase your strength, which will help with your balance, decrease your risk for falls, hip fractures, mortality. So all that goes hand in hand, yeah.
I read where muscle mass is longevity. All right, let's talk about the heart. That's a big one, okay? Let's just open this up. How it is heart protective and the people who can't have it. So in general, when you're on your hormones, you don't let the cardiovascular disease, and of course we've talked about you can't just eat all the bad foods you want and take your hormones, but hormones for women when they have the replacement is cardioprotective.
Yeah, it can be. I mean, what happens when we lose our estrogen is you get insulin resistance. And you can see it in lab work. Women who seem to be doing everything right start getting some insulin resistance, and also their cholesterol can go up. Where it gets tricky, and we've talked about this a lot in our group because we see high-risk patients, is there are some women who already have pre-existing cardiovascular disease. So if you give them estrogen, that ship has sailed for their cardio protection.
Right.
So we don't want to cause the problem. So that's why we often do cardiac risk assessments to check for cardiovascular disease, because we might be the only physician they're seeing, and we want to make sure we're sending them down the right path in terms of getting their cholesterol under control, having the clean diet, exercising. But most women, estrogen is a good thing for their heart, but we really kind of
Yes,
take a
and we
different
should
look
tell
at
everyone is individual and needs to see her doctor. This, going on with heart, this was so interesting to me about metabolism. So there's a regular fat that we complain about on our thighs and maybe our upper arms, but there's the VAT, the visceral abdominal tissue, which is the metabolically active fat that's around your waist and around your organs. And we think of it in men as a beer belly. And that's the dangerous kind of fat. And I read where it is metabolically active, linked to 7 out of 10 causes of death in women who are going through menopause. And it's not necessarily calorie driven, it's your hormones and inflammation, and it's related, as we talked about, heart disease. So when you're on your estrogen, that helps your metabolism and your insulin become at the right levels so you don't store this dangerous deep tissue fat.
Yes.
And I've seen scans of women who were morbidly obese and women who were normal weight and thin, but they had the same amount of visceral fat.
Yeah.
And yet trainers will say, well, just work out more. But if you don't have your estrogen, your insulin can be not operating correctly. Is that, y'all
Your
see
body
that?
starts fighting against you somewhat.
We know, in reading, a lot of the studies and things that we have read through the years, we know when you start to lose your estradiol, the way you deposit fat because of those reasons is completely different. So, when you're younger in those reproductive years, we tend to deposit fat around our hips and our buttocks, in more of like a what we call gynecoid fashion. And then as you start to lose those hormones, it starts to become more of an android type of deposition, which is the abdominal obesity. And so we know this to be true when we see it all the time. That's one of the biggest things they come in with is like, I just feel like my belly is just getting bigger and bigger and bigger, no matter what I do, no matter what I eat, no matter how much I exercise, I can't lose it. And so I think that's probably one of the biggest things.
And when they get on their estrogen, is their insulin more stabilized so they're not storing in the dangerous area?
It's not a magic pill. I think we're the
Right.
first
That's what I was
to
gonna
say, I would love to
you don't
see
do
you.
it. Yeah.
Agree.
And they're not magic beans. You don't go on estrogen and all of a sudden lose
That's
them.
right.
But does it help them?
But what I tell them is it can help. It is definitely, I think, part of the treatment. It should be part of the treatment plan, and it should be discussed, because in some cases you might kind of hit that wall and be fighting that losing battle, because if their hormones aren't right and they are insulin resistant, they may never be able to reach the goal that they're trying to reach because of their metabolic rate and different types of things. But I stress weight-bearing exercises, resistance training. That's one of the biggest things. Going back to what Dr. Horton was saying is, I think women, especially in their late 30s and early 40s, I had a patient recently ask me, she said, Doc, I've just turned 40. If you could give me one piece of advice, what would that be? And I had to sit for a second. I was like, man, that's a great question. And I said, I think what I would say is, I would say resistance training, and forget the cardio, or not forget the cardio, but don't worry so much. I think we focus so much in our 30s about, being slim and fit, and we stress cardio. I'm like, don't stress about that. What you really need to start worrying about now is the loss of muscle mass and all of the other repercussions that come along with that.
Because when you lose muscle, your metabolism slows down.
That's right.
You know, a pound of muscle takes more calories just sitting here than a pound of fat. And there was an interesting studies have come out with, of course, the Ozempic and the GLP-1 injections. And what was interesting was that women who were on their HRT and took the injections, okay, because they had dysregulated leptin, ghrelin, dysregulated hunger hormones, they lost 30% more than the women who took the GLP-1 injections but weren't on their estrogen. Have y'all seen patients who are on the injections and HRT?
Yeah.
But I think it's so important, though, that you really truly have to change your lifestyle.
Yes.
So it's not, again, you can get all the medications and everything, but you still have to change your sleep, you have to change your exercise, you have to change your diet, because you can follow an anti-inflammatory diet, plant-based diet, Mediterranean diet, all of those things that will help, because that's what's going to be helping you long term, and it's going to give you the good quality of life that you want, versus, you know, I'm just going to take these medications and people absolutely do feel much better, but you have to think of those lifestyle behavior modifications as well.
That's a good point. If you're on your hormones, you feel better, so you maybe feel like going out and doing the exercise.
Oh,
And you
absolutely.
sleep better. And you sleep
Okay.
better.
Sleep better, yeah.
All right, let's talk about vaginal dryness, more likely to have urinary tract infections, and not to mention that it hurts your sex life as well. So when you're on your estrogen, your vagina doesn't have to dry up as like women who aren't on their estrogen.
So I'm a fan of vaginal estrogen. It has so many benefits, little risk associated with it. Not only does it help with vaginal dryness, it helps with painful intercourse. It maintains a normal vaginal pH, increases the lactobacilli that you find in the vagina that helps prevent infections like yeast, bacterial vaginosis, helps with pelvic support. So it has many, many benefits. So I'm always a fan of vaginal estrogen.
No risk. And no real risk.
Yeah,
Yeah, there's really
no risk.
No risk.
Yeah.
Okay, what about joint pain? I understand, what is it, like a third of women who starting to go through menopause and they start to get joint pain. It's not necessarily arthritis, it's that they don't have their estrogen. Why is that to any of you? Why does that happen?
I think a lot of it has to do, and I know, even like the NAMS position statement does talk about all
That's
the different.
North American Menopause
Yes, I'm
Society.
sorry. Yes, talks about all the different areas in our body where estrogen affects. I think the biggest thing that women just need to know is that we're women. We have estrogen receptors everywhere in our body. So that's including your, potentially your joints. And so it would be crazy of us to not sit up here and say that there is probably some benefit to being on hormone replacement therapy and your aching joints. Now, is it the indication for hormone replacement therapy? Probably not, because not everyone are going to see those benefits. But I have definitely had patients that have autoimmune, like rheumatoid arthritis, who have definitely noticed a decrease in the number of flares having been on HRT. And so, I do think that there is definitely some correlation there. But I wouldn't, if a patient came in with, as that was their only complaint, I wouldn't necessarily say, okay, that's my indication to put them on. But definitely another benefit of HRT.
Okay, fibroids. You can have fibroids and be on your hormones, correct?
Yes,
okay,
absolutely.
because
Yes.
some doctors have told my friends, oh no, you can never take hormones, and they're miserable and they're falling apart. Okay, let's talk about clotting disorders. There was ACOG, that's the American College of OBGYNs, came out in 2013 and then reaffirmed the study in 2020 that estrogen only, it's not, transdermal is not going to affect you having a clot, having a blood clot. Do y'all agree, or you want to talk more about that it's safe?
Yeah, I mean, in most patients. In most patients. If somebody has an underlying clotting disorder, that's different, and those are the people we see to help. But for the most part, yes, it's safe.
Okay, let's talk about hair, facial hair, that type of thing. When I went through puberty, I needed the wax and the tweezers and all of the above, and the electrolysis, and now it's just laser. And there's some women who say, oh, I don't want to get on my testosterone because I may get facial hair. But it's so easy to pluck or wax, but yet what it does for your muscles in your body, you know, it's just like when you were a teenager, you had to take care of that. What do y'all tell your patients about, you know, they go back on, they have normal testosterone for a young person, so it's replaced to be normal. You're going to get a few of those little side effects like you did when you went through puberty, and that's normal. Okay.
You're gonna
I
get it
just look
without
at
it.
You might not get them at all.
Yeah.
Yeah, I
You might
just
not.
weigh the risk and the benefits. You know,
Yes.
like
Yeah.
what the reason why you're going on testosterone, and you know, I go through the risk or possible side effects, and you know, most times people are like, no, I just want to feel better. I
Yeah.
can pluck
Yes.
those extra
Yeah.
hairs and I'll be fine.
Exactly.
Yeah.
Yes, and we all do.
Or they say I was getting them anyway.
Anyway,
you know?
yes.
Because
Or
a lot of them
laser.
as they're a lot of
Yeah.
times they're transitioning anyway through menopause. They start to get the whiskers, you know, because that ratio of estradiol and testosterone starts to become different because you're losing estradiol. I mean, yes, you are losing testosterone, but at estradiol at a much quicker rate, and so they get the whiskers anyway. So most of them are like, I was already plucking, so what's a few more, you know?
Laser at the dermatologist. Is there any difference between different ethnic groups, African American, you know, no matter what, with hormone replacement, or are women treated basically the same?
Well, I think African American women often have a more difficult menopause. Their symptoms can be more intense and longer. There's data to support that. I think we treat them the same.
Yeah.
I mean,
Yeah.
you know, but we
No
just,
different.
No
yeah,
different.
Yeah.
Okay. And I promise people we talk about breast cancer. I read something, a study where when you on a hormone replacement, non-oral, so you're getting it, like you said, through patches or injections, or some people with implants, that there are metabolites made that are protective against breast cancer, 23% lower risk. So what do you tell people who are like, oh, I don't want to go on hormones, so I'm going to get breast cancer? But now we know drinking alcohol increases your risk of breast cancer. So just open it up to all of you to
I feel like that's
talk
actually
about,
pretty equivalent. Like, if you actually look at the data, your risk assessment drinking alcohol is higher with its association with breast cancer than hormone replacement therapy is. And I think that if you actually put it in those terms, they look at you like it's
a little different
astounding.
perspective.
Right.
It's a whole different
Yeah.
perspective. I agree. I was talking to some of the internal medicine doctors at Ochsner who they didn't even realize that. If you actually look at the attributable risk, so what is the risk that you can attribute to breast cancer from HRT? It's less than 1 in 1,000. And so people feel like it is a much higher risk than what it really is.
Because
and
of
so,
the WHI study.
and it all goes back to the WHI. And so, and that's why we're sitting here today, because we're here to try to tell people you don't have to live this way.
In a story we did a long time ago, Dr. Brene, you taught me that that women who end up getting breast cancer, and they happen to be in their hormones, not necessarily that the hormones caused it, they find it sooner, it shows up sooner, they get it sooner, and they live longer.
So the prognosis is actually better. And
Yeah.
so that's the thing I do tell them. You know, at the end of my talk, I say, look, 1 in 8 women get breast cancer, right? So we're already looking at a cancer that's got a high incidence rate. So 1 in 8 women get breast cancer. So what I tell them is, at the end of all of this, okay, that you have to look at what is your quality of life. And you can get breast cancer anyway, whether you're on HRT or not. Most women are actually not on HRT that get breast cancer. But in the data that we do have, the prognosis is better for the women that are on HRT. And whether that is because, you know, it makes it grow a little bit quicker because, you know, if they are hormone, so it's able to be picked up on an annual screening mammogram, which is why we do stress. And for a lot of us, as far as like refills for hormone replacement, we're very, I don't know what the right word is, but we're pretty good about like, look, you got to keep up to date with your mammograms. And then I've had patients like, well, will you worry about breast cancer? And I'm like, no, I'm not. It's not because I'm worried that HRT is going to cause breast cancer. But what I do think it will be is that if you have an occult cancer there that's not being picked up yet on mammogram, and we start HRT, yes, it could potentially feed it, but I want it to be picked up on, and I want it to be caught so that you're at an earlier stage where your prognosis is better.
Well, I think it's no different like when you check their cholesterol
Yes.
levels, their blood pressure, you
Yes.
assess their cardiovascular disease risk. It's all part of that, you know, intake before you put them on hormones.
Yes.
So yeah,
Overall
you want to make
wellness.
sure. Yeah,
Overall
We're just trying
wellness.
to improve
That's
their
right.
overall health outlook.
Yeah.
That's right.
And I read that 85% of women complain about symptoms but 10%, this is going back 2 years in 2023, only 10% got treatment, went and got hormones.
That's true.
Are y'all trying to change that one patient at a time? Or?
Yeah, one patient at a time.
Yeah.
Well, I think it's always helpful when I tell patients, so I'm going through this, you know,
Yeah.
and they're like, oh, so you know what it feels like? And I'm like, absolutely. And, you know, I tell them what I'm taking or, you know, how I felt or things that I've changed. You know, I'm always trying to be better about, you know, making lifestyle changes, improving my sleep and, you know, exercising, improving my diet, although it's hard here, but.
And you've recently moved here.
Yes, it's a challenge,
Yeah.
but, you know, I think then it's something that's relatable and, you know, I think that makes it a little bit easier too.
But that's why we have specialized consults. It's hard to do this in a well woman exam when you have like a bunch of other patients. These women need time because a lot of times they haven't been listened to, not through anyone's fault, but they need time, they need the expertise, and so that's why we have specialized consults, so we can give them the time and the expertise.
Final thoughts? Anything we didn't cover that you think is important to mention to menopausal, especially menopausal women?
I just encourage people to even just get the consult and talk to, you know, someone who's really well versed in hormone replacement therapy because you want to not just live your life, you want to live a really good quality life. You want to be that like feisty 80-year-old who's still playing pickleball and going out to socials, not the one that's, you know, hunched over and has, you know, pains or, you know, you want to age gracefully. You want to live your best life. This is the time that, you know, you want to travel and do fun things. And so this may be the way to do it.
And just as important, a lot of us are still working well past menopause, and you have to get up and go to work every day. And if you feel rotten, okay.
Well, and I think the other, you know, takeaway is, like we said before, one patient at a time, we take away at this. And so even when I'm seeing younger patients for annual exams, you know, they're in their late 30s, early 40s, and they start bringing it up, I start telling them, don't be afraid of it. When the time's there, come back and we can talk about it. And I encourage women, if you see a doctor and they're telling you, oh, you don't need that, you'll be fine, just do it gracefully, get a second opinion. There is no need to do it gracefully, and doing it without hormones does not mean that you're doing it gracefully. That's actually the hard way to do it. And if you actually come in and learn about all of the different benefits that HRT will have for your body, you will start to realize that this is something that you should do for your health.
Okay.
This isn't an old age thing. I think that's like what's been kind of touted and women have kind of been pushed aside. This is a time to like take control
Be your
of your
best
life.
self.
Be your best
That's
self.
right.
And then there's 30-year-olds I know who had a hysterectomy and they're on the hormones. So not an old
And
age
look,
thing.
and survival, you know, our longevity is getting longer and longer and longer. So we're starting to see more women that are living a majority of their, you know, their time with us in menopause.
40% of their lives
Yeah,
in
and
menopause.
so I think for the doctors out there that are afraid of it and don't know a whole lot about it, read, go get educated on it because, you know, the answer is not just do it, just go through it gracefully. You don't need it. And
a lot of doctors haven't learned this emerging science that
they're in the same dark ages of the patients and following the data from the Women's Health Initiative, which we now know is not true.
In 5 years, in 2030, there'll be about 1 billion women in menopause.
Yeah.
So, I mean, there are a lot of us, I'm one of them, you get a lot of us to take care of.
Yes.
Yeah.
Yes, and if they take my hormones out of my cold, dead hands.
Exactly.
All right, ladies, thank you so much. It's been so enlightening. Hormones and your skin. Estrogen in your skincare is the latest buzz in the beauty world. So, can anti-aging creams with hormones deliver results? Could this be the secret weapon in the quest to reverse wrinkles? Next on Message Meg, we're breaking down the science behind the trend and what you need to know about adding it to your routine. Now we turn to estrogen and the effects it has on the biggest organ of our body, the skin. I'm sure you've seen on social media and companies advertising to buy face creams for anti-aging with estrogen in them. So what's the latest science on that? Well, here to explain is board-certified dermatologist Dr. Mary Lupo. She is often on the forefront of clinical trials for the latest anti-aging treatments and lectures to doctors all over the world. Dr. Lupo, thank you for joining us.
My pleasure.
Estrogen receptors are not just in the female reproductive hormones, they're everywhere.
Yes, I think the way I explain it to my patients is all hormones work on the fundamental principle of a lock and a key. And so in the example of skin estrogen receptors, there are receptors specific to the skin for estrogen. And think of the estrogen as like a circulating key and the receptor as the lock. And when you have the key hit the lock, there's a biological effect, all right? So what we're talking about with skin aging and the effects of estrogen via the estrogen receptors on the skin is that when these receptors are activated, it improves elasticity of the skin, collagen, skin repair when it's injured, and overall rejuvenation. Also remember that hormones are always about a balance, a yin and a yang. So I'm a big, big proponent of systemic hormonal replacement treatment for menopausal patients because of the myriad of advantages that, in my opinion, far outweigh any disadvantages. And when I'm asked by my patients, I always tell them that the optimal way to address the aging of the skin as a result of getting older and going through menopause and having your estrogen decrease is to get on hormonal replacement therapy. Now, that's complicated depending on what's going on with the woman. For example, if a woman has a uterus, you must also give them progesterone because estrogen causes a hypertrophy of the lining of the uterus, and you could theoretically be at increased risk of uterine cancer if you didn't have the progesterone to balance that and prevent a hypertrophy of the uterine lining.
Which is just what we do when we go through puberty. You have your estrogen and your progesterone. Well, let's start with one thing before we get directly to the skin. A lot of people don't know that a big part of aging in your face is the loss of bone. And we know from decades of science that estrogen replacement keeps you from your bones becoming Swiss cheese. They literally get holes in them. That's why older women get the hump on their back, and that's why they break a bone, and a lot of them end up dying if they break a hip. Okay, so aging and the face with your bones aging.
So that's incredibly important because part of the senescence of the face, it's not just the skin. Think of the skin as the paint job, but the bones are really the bones of the face, the scaffolding. It's kind of like if you've got a table with a certain type of tablecloth, if the table is shrinking, the tablecloth is going to sag and sink more and not look right. So when you're on hormonal replacement therapy with estrogen, you're preserving your bones, not just of your spine to prevent collapse and impinged nerves and shrinkage of height, and your hip to prevent hip breakage, but also your other bones. Broken arms, broken shoulders are much more common in postmenopausal women.
But cheekbones and
exactly.
forehead,
Cheekbones,
skull?
Specifically, it's the thinning of the cheekbones. The cheekbones get much, much thinner. Instead of being, I'm exaggerating, instead of being this thick, it's this thick. And you get this sort of sharp, gaunt look with age. And then your orbital rim widens and tilts down.
Sunken in eyes as you get older.
It's the erosion of that orbital bone. And then there's the mandible. As it shrinks, it has a very negative effect on our teeth, which has a very negative effect on gums, etc. And when you do not have a strong chin and jawline, you get more jowling and sagging of the lower face. So, it's very difficult to tease out one thing. It's all interrelated.
Okay, well let's continue on that. Okay, there was a correlation. This fascinated me with biology and attractiveness. So correlation, the level of estrogen, when other people look at you and you have the right amount of estrogen, you replace it after menopause, people perceive you as looking younger, they perceive you as more attractive, your skin looks healthier to them, and your facial coloration is even better. You have an overall youthful appearance. And this was interesting, more collagen, more dermal thickness, more elasticity, and more water content in your skin. And that's important for healing. So talk about those.
So, a lot about biology and male and female is about signaling. And who amongst us has not said to a newly pregnant woman, my God, you're glowing? Well, that's the estrogen, all right?
300 times the estrogen.
Exactly. So estrogen, it has a very positive impact on the skin. It actually can make the pores a little bit smaller. In contrast to progesterone and testosterone, which can make the pores a little bit bigger. So besides the clarity of the skin and the messaging that our hormones give us, you know, biologically, we are still wired to find attractiveness in a mate and reproduce. That is our anthropological wiring, if you will. So when you have high estrogens, just as a man with higher testosterone will be found attractive by the women. And in nature, there's plumage differences and there's other things, but there are these small messages that you get very subliminally to give you the message of this is a person who's vibrant. And that's the thing about being postmenopausal and doing estrogen, is it keeps you with a vibrancy and energy. And I think it's all related.
Okay, so this is interesting. Your peak level of estrogen in women is late 20s. By the time women hit 50 years old, it is half gone. And then you go through menopause and it's a huge difference. So we talked about earlier with the doctors, the vaginal dryness, but we shouldn't think of it as just dryness of the genital area. It's doing that to our skin. So what surprised me in the studies, Dr. Lupo, was in wound healing. I have seen my mother, I have seen my aunt, people, the wounds they get as they go in the nursing home and age. But estrogen helps you with that type of thing, wound healing, as well as being not losing as much skin.
Well, if the skin has good, what we in dermatology call good ground substance, which is the stuff in the dermis, and it's chondroitin, glucosamine, and hyaluronic acid. Those are the things in the skin that give it spring and the ability to hold moisture. Dehydrated skin is not going to heal well. And dehydrated skin is going to be more easily injured and torn and bruised, if you will. So all of those things, it's all interrelated. And my message to my patients is hormonal replacement therapy is a discussion that you must have with your gynecologist. And it needs to be one that you feel fully informed about what are the risks, what are the benefits, and like everything else, you make an informed decision when you weigh the pros and the cons. For me, I'm 70. I have been on HRT since I'm 51 years old. And you know that old joke about guns, they can take my gun away? Well,
out of my dead hands.
Well, you can take my estrogen. There are two things you can't take away from me: is my estrogen and my thermostat,
or my testosterone. Okay, now this is so interesting, and I was told this by my OBGYN father decades ago. That so the estrogen has been shown to increase the cellular activity, but it also is, and as you said, we have estrogen receptors, the lock all over our body, but the face has more than the thighs or breasts. And we think of your breasts as a very female trait. You go through puberty, you get breasts. But the skin on the face has more estrogen receptors. So that means, so my question is not only taking your hormones, but here is vaginal estradiol cream. You have said that all these creams that are on the market by companies, you just get the prescription vaginal estradiol and you can put it on your face. And what does that do?
So studies have shown that it thickens the dermis and it improves wrinkling. It improves the water content of the skin, so it improves hydration. So it has all of these positive effects. But my position with my patients is there are so many really good skincare products out there. I personally prefer my patients to get their estrogen systemically, and they use other things topically on their skin that address the aging issue from a different vantage point.
Cross-training, I've heard you
Exactly.
say.
Yes.
You don't just weight lifts or just jog, you do
Right.
both. Okay.
So, and when you add an estrogen cream to your skin routine, it's another step. It makes it very complicated. What's the order in which you do it? I'm not saying you shouldn't do it, you can't do it, but you should talk to your dermatologist about the order in which these products should be used. And what if you're using a topical retinoid that's a prescription retinoid? What's the order that you use all these things
What is the
with?
order?
Well, as a rule, a lot depends on the vehicle. And the vehicle determines how well it goes into the skin. So the general rule is serums before lotions, before creams, before ointments.
Okay.
So the heavier and more emollient it is, because if you put a cream on, you're not going to get that serum through that cream.
I understand. Okay.
So that's sort of like a good rule of thumb, and you picked the right one because estradiol topically has been found to be the more effective rather than estriol. So estradiol is the one that if you're going to do it, that's the one you want to use.
Estradiol. Okay, I have one more question. I read that an important function of the skin is it's an endocrine organ. An endocrine organ, meaning that's hormones. When you think of your endocrine system, you know, you think of the stress hormone, you think of, so it is actually acts as a
No, to me,
What does that
it's
mean?
because the skin is so receptive.
Oh, okay.
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 So, for example, cortisol, our stress hormone from our adrenal gland, has profound effects on the skin. Who amongst us hasn't had a friend who went through a purely emotional trauma? No physical, no health, but a trauma. Death, divorce are the two big
Yes.
ones. And they look like they aged 5 years in a matter of weeks or months. Cortisol is a disaster for your skin. And let me also make a very important pitch for systemic hormonal replacement therapy in the hair. Estrogen grows the hair on your head, makes it lustrous and thick and vibrant. You can't get that when you're using that topically just on your face. And yes, the face has the most estrogen receptors, followed by the breast, followed by the thighs. It's got to be that that's the order in which the males check the women out.
Well, of course, our biggest sex organ,
Is our
the
face.
first thing someone's going to see is the face. Okay, well, I'm convinced, and I know it. I know all these studies are it really does make a difference.
Yes.
So the systemic, and then you can add some on your face. Anything else, Dr. Lupo?
Well, the most important thing is to have the conversation. Women need to be their own advocate. And a lot of times with regular medicine, unfortunately, doctors have a limited amount of time that they are delegated now by the insurance payers of how long they can talk to you, which is unbelievable that you've got an insurance company as sort of like the chaperone between the doctor and the patient that is inhibiting contact. You know, we understand why the chaperones inhibit the contact years ago, but this is inhibiting contact between patient and physician. And you almost have to, unfortunately, demand the attention to have the discussion. And I wouldn't apologize for that. I would insist upon the discussion.
All right. Dr. Lupo, board-certified dermatologist, thank you. We've explored several areas on women and menopause, but what about men? On the next Message Meg, men go through hormonal changes too. It's called andropause, and it can affect everything from energy and mood to sexual health. Is hormone therapy the answer? In the final part of our hormone replacement series, a leading urologist joins us to separate fact from fiction and explain the real risks and rewards. That's next Wednesday at 9 p.m. on WWL+. Stream it live or watch anytime. Just download the app on your TV and watch it free. And to get in touch with Message Meg, email messagemegshow@gmail.com.